want to thank them once again for honoring our invitation. And we were really thrilled by such a marvelous presentation. And we heard from experts and trusted authorities in the field of pain management, what we could do to improve pain management during labor and delivery, while still considering our tradition and ethics and everything that has to do with the journey from pregnancy to delivery. It was such a great presentation, but of course, every week is always exciting. Today, we are going to have yet another very exciting topic coming up our way, and we are proud of who we are because we have all kinds of experts who are healthcare professionals from Cameroon origin. We have from neurosurgeons to cardiovascular surgeons to, hemato-oncologists, all kinds of experts. Cameroon is that country that if you want to find healthcare experts from all dimensions, then you have to think about Cameroon. We are truly proud of who we are. I'll be moderating this session today with Brian Tegomo, who is here with us. Brian?
Yeah, hi everyone. Welcome to the 30th edition of the Town Hall. It's really great to see you all. Really looking forward to this exchange.
Elvis, your volume, please.
So it's really an important subject that really touches my heart because it's the discussions around sustainable surgery across Africa. It's really something that we really have to tone on the need for both infrastructure and technical skills. Just really having this conversation and across the continent is really something that we really need to talk about sustainability. So I'm really looking forward to this exchange, and especially the discussion after the main discussion after the town hall. So we're really excited to see everyone. I see Christelle is also on the hall. Christelle, welcome.
Hi, Brian. Hi, everyone. It's a pleasure to join this edition of the town hall. I'm looking forward for the various discussion and exchange. Thank you.
Awesome.
Elvis, we can't hear you for some reason.
No. Oh, we can hear you.
Can you
yes, we can get you now perfectly.
Oh, thank you very much. I really apologize to our audience for the technical issues. So today we are not going to have Alison because she's really committed with other duties, as well as Louisa. Louisa might join us subsequently. So we're going to be co-hosting the session with Christelle and Brian Tegomo. Christelle, bienvenue une fois de plus.
Merci Elvis.
Okay.
Bienvenue à tout le monde à cette édition de Cameroun Town Hall. Et nous espérons que chacun gardera des échanges fructueux tout au long de la discussion. Merci.
Thank you. And as usual, we are going to start the town hall with some updates on COVID-19. From our own chair, Dr. Muno Kenneth, I hear that the Delta variant is ravaging the world once more. Can you give us update what's happening around COVID-19?
Yeah, Elvis, thank you very much. And, COVID has been part of us for almost 1.5 years now, and it's become part of who we are. Really, we need to learn to live with it. So I usually get my weekly inspiration by discussing with Brian, who is at the CDC all the time, and we have little chats about what the future may hold. So this just shows you exactly what's happening. We're having some resurgence actually in the US, and we're trying to get to the finish line. We thought we're getting to the finish line. The virus is running ahead of us with the Delta variant. So just showing you exactly right now we have the Olympic Games going on, and there have been some few reported cases, but the Japanese are doing a good job at the moment. So the Delta variant is really a big issue. The question is, how are vaccinated people doing in terms of the Delta variants and the different variants that are popping up? We know other variants are going to pop up. So here is just a dream idea on how to create a dream virus, the dream vaccine, which is to target all the epitopes that we have. And I think this is something which is feasible and can be done down the road. So COVID, it's still really very rare among vaccinated people. And also those who are vaccinated, actually when they get infected, even with the Delta variant, they don't get very sick. So it's a good thing. But the bad part about the whole issue of the Delta variant is that we're getting some breakthrough infections, and the viral load among those who are infected who have been vaccinated is pretty as high as those who are not vaccinated. So here it just shows you exactly how the Delta variant's level of transmissibility compared with other infections that we have had in terms of severity. The severity is not really different from the other strains of COVID, but the level of infectiousness is maybe higher. So we know that RNA vaccines still work, about 88% among the Delta, among those who are vaccinated, those who are infected with the Delta variant. We know that Delta variant is more infectious. This is a summary of what the CDC laid out yesterday. And we know that Delta variant has a faster increase in viral loads. These are all things we know. So I think based on all of this, we know that these strategies we have had and we have used all over the past 1.5 years, we need to put them together. Vaccination alone is not going to solve this problem. And we need to make sure that if we're in closed doors, closed spaces, we need to put on our mask. We need to continue working on therapeutic means, better ways of testing, and also continue some form of social distancing without locking down, and try to get better vaccines. And I think a booster dose is going to come up soon. And as I said earlier, this has been a phenomenon 1.5 years for the human race, with humans discovering a virus and actually getting a vaccine within a year. It's amazing, and it shows you how much we are capable of doing great things. So here is the number of cases of COVID we have had. We have almost reached 200 million cases. I think if we're counting, and we have reached almost 4.5 million deaths from COVID worldwide, which is a big issue. In the beginning, if this was told to any scientist, they wouldn't have accepted. And we've vaccinated about 4 billion people. Half of the world, we have used about 4 billion vaccines so far. So about 2 billion people have been vaccinated. So it shows you that a lot of people have received this vaccine. The burden of the disease is still in the West. And this is more due to socioeconomic reasons, more of transportation, free movement around. And here you just get to see what the burden of the disease is in different areas of the world. So this is as of yesterday, the number of cases that we have. During the last 1 week, we've just had, or 2 weeks from the last time we presented, the number of new cases are actually reducing. We've had just 7 million cases around the world and just about 200,000 deaths, which is a good thing. In Cameroon, based on the data which I got from WHO, the number of cases are pretty low in Cameroon at the moment. I hope we get vaccinated in order to prevent ourselves from getting new infections. South Africa still remains the epicenter in Africa. The US remains the epicenter in the world in terms of the number of cases that they have had compared to other places. And you get to see the difference, the impact of the Delta variant. Just in May, there were very few cases in the US. In July 16, you could see the number of cases started increasing. And this is today, the last slide showing the red. These are the states. Those states are similar. For us, those in the US, you see those are mostly Republican states where vaccination hesitancy is high. This, as of today, 4 billion doses of the vaccine have been given out. There is still vaccine inequality going on in the world. Majority of the vaccine is found in the countries that are very developed, while those that are underdeveloped are rarely getting vaccines. There is some level of social justice trying to provide vaccines to those who cannot afford it. And when is life going to get normal? It depends on where you are. In Europe, the rate of vaccination is getting is fast. So in the next 2 months, most likely, but with the Delta variant, there are some escapes, so they may need to give booster doses. That's going to be a discussion of another day. In the US, the level of hesitancy is more than that in Europe, which is strange. And the US, at the rate at which the US is going, is going to take them about 9 months. And other areas in the world, Cameroon will take 10 years. At the rate at which we're going, the number of doses we're giving is going to take us 10 years to get herd immunity. And are we actually burning the curve? We were, but with the new results we're getting out of the Delta variant, we may not be. So it's an alarming situation that we need to take care of right now, get everyone vaccinated and prevent mutations from occurring. And also, we do know that there are different kinds of vaccines that are available and different ways in which we have spoken about this before, different modalities. Back in Cameroon, we do have AstraZeneca, we have the Johnson & Johnson vaccine, we have the Pushnik vaccine, we have the Sinopharm and the Sinovac, which are available in Cameroon. And I would say get whatever you have your hands laid on. But the Johnson & Johnson looks pretty good. It's a one-time shot. Cameroon got almost 1 million doses that was sent by the US as a donation. So I think everyone who is back home should be encouraged to get it. I know there are so many rumors, and the thing about life is that bad news travels fast, but really this is kind of real stupidity, in the sense the number of messages I get about the things people believe in can be amazing. So I think education is necessary. The Delta variant, as you see here, is more transmissible. It also escapes the immune system more than the other viruses, but it's also efficacious against the different vaccines we have. Here is just showing you, compared to other diseases that are very communicative diseases, how the Delta variant does, which is really worse than the others. So you can see here that all the vaccines have a certain level of efficacy against the Delta variant. Here is a summary of the different virus and vaccines that are available. For those who are interested, you can always take a look at it, a summary of it, and you know exactly what you're taking and what the benefits are. In terms of therapeutics, we have not gone far. There are just 3 main drugs that have been shown to have, or classes of drugs that have been shown to have activity against patients who are severely sick. Steroids, which is dexamethasone, and we have our JAK2 inhibitors, that's baricitinib and tafasitinib, and you have tocilizumab, which is the drug of choice. You do have other investigations going on. Monoclonal antibodies do work. They're expensive. They are not available in Africa in most countries. And here is just a research guideline into things that are being carried out. So there are other drugs such as ivermectin, where the research is not conclusive, colchicine, and you have other antipsychiatric medication. Hydroxychloroquine doesn't work. Convalescent plasma is difficult to administer and to research. So we can see here that in terms of therapeutics, not much has been done. In the outpatient, we do have monoclonal antibodies, and we just have to put on our mask and prevent ourselves from getting infected in the first place. So Elvis, I want to thank you for always giving me the opportunity to give updates concerning COVID. What the take-home message today is that we need to really be worried about what is going on concerning the Delta variant, but there is hope. The hope is that those who are getting sick, who have been vaccinated, are not getting severely sick. Majority of them are not getting to the hospital, which is a good thing. So I encourage everyone to go get their vaccine. The rate of vaccination in Louisiana has actually spiked almost 100% based on this new information. So thank you very much, and I wish everyone the best, and let's continue the discussion.
Thank you very much, Ken. If you could stay just for a minute, and our dear audience, you know, I always say that if you don't have time to know what's happening around COVID-19 in the world, just wait in a fortnight and you hear it from Dr. Munoken. But here in the United States, there have been this issue around communication and, you know, the issue about mask mandate and those who have been vaccinated being asked to get back to respect mask mandate. What is your take on those who have actually received their vaccine and the mandate of requiring that they put on masks even in closed doors?
So in the first place, you're going to get information from someone who is originally biased. Why? Because I am a mask advocate from the beginning, and it was based on empirical data. I'm a big mask advocate. Why? Because when the pandemic started, we were in the midst of the pandemic here in New York. Then my hospital had over 500 COVID patients at a certain time. I'm not sure anybody here has seen what we saw concerning COVID. Nobody. Our physicians, we have about 200 residents. In the first 1 week of this pandemic, about 20 of them got sick and were not putting on masks. After the mask mandate in the hospital, till now, not up to 5 of them have been sick. It shows that masks do work. Empiric data shows that China had the pandemic before everybody. They still have a mask mandate and they have not had any spread. I know we want to be emotional about things. Masks do work. You don't need to be a rocket scientist to that mask work. I know people have gone through all kinds of research. I am not an advocate of shutting down the economy. It becomes a political whole statement, but I'm an advocate of people using sensible public health information. I'm a public health physician too. Sensible public health information to guide policy, meaning that if you're in closed doors with people who have not worn masks, how do you differentiate in Walmart those who have worn a mask, those who have gotten the vaccine from those who have not? You're not. And now that we have this data variant, is showing us exactly masks can become part of the culture till we get to deal with this virus. And truly putting on masks, it hurts at times, but truly it's something that is going to end the pandemic sooner in addition to getting vaccinated, in addition to doing other things that could help. But as I told you, and I actually appreciate the fact that my mask advocacy could be biased. And my take on this question will really relatively be biased because I've been a strong critic of the CDC. You know that for long, the WHO and many others concerning what I call logical and common sense public health measures. You cannot appease political will and at the same time carry out public health measures.
Thank you, Mono. I will take it from you now, and thank you so much for your response. And I put Brian on spot now. Brian, you work at the CDC, and you at some point been one of those who have really worked hard when it came to trying to map the different variants around the world, the strategy of actually doing a lot of variant mapping. Will you say that it is the virus that is changing, or it is the CDC that is changing its policy, and who should be blamed?
Well, Elvis, thanks a lot for the question. I've had strong debates with Dr. Mono prior to this call, but I think we've been extremely humbled by this virus. There's so much that we didn't know, and it's just been a work in progress. I think we've just been building the plane as we've been flying it. One of the most strange findings this week was this phenomenon that people who are fully vaccinated with vaccine breakthroughs harbor the same viral load as those who are unvaccinated. That's very strange. I was expecting that the cycle time for those who are unvaccinated will be much lower among those who are vaccinated compared to those who are unvaccinated. That's very strange. We did not see this with the other variants. We did not see this with the wild type. We did not see this with Alpha. So I think we've been extremely humbled by this virus, and we are learning new things every single day and updating guidelines and making progress. I don't think contrary to what Dr. Mono said, I think that we've been making the right decision based on the evidence that's available.
Thank you very much. And we are all proud that you guys are all trusted authorities in this field, and whatever your views, they are very scientifically backed, and no one is absolutely, can predict what the virus will transform into the next day. So Dr. Fauci said the virus is the one changing, we are not the one changing. So thank you so much, Brian and Dr. Muno. Away with COVID-19, now let's talk cardiac surgery in sub-Saharan Africa. Are we getting there anytime soon? Today, we are going to be talking about cardiac surgery. In Cameroon, I'm sure if you must have known at least one person who have had a cardiac problem. If it is not your friend, it should be a family member. And you might have known the difficulties they went through, either getting treatment or just getting access to care. Today, we are going to be fortunate to talk to to have a conversation with a trusted authority in this field, who has had quite a really, really lengthy educational path as far as cardiology is concerned. Dr. Clarence is going to be with us today. Just give me some moment while I put him on screen before I present him. I'm putting, let me, Mono, let me take you off this the pin so I can bring Clarence on. I want you to, can we have Clarence here? Or okay, right here on our screen is the person I'm about to present to you. So Dr. Clarence Piancho Pingpo is a Cameroonian who went to primary school in GBPS in Gaoundéré, and he went to secondary school in Sacred Heart College, Mancon. And he left and went to med school in Albert Ludwig University, Freiburg in Germany. And after his med school, he did a master's degree in health business administration at Friedrich Alexander University at Elegang, Nürnberg in Germany. After that, maybe we would expect that he'll get into some health business and start doing some consultancy, but no, his passion for cardiology pushed him to start his residency in cardiac surgery at the University Heart Center Bad Kreuznach in Germany. That was in 2007. As if that was not enough, Mr. Book went ahead again to do another residency in vascular surgery in the same university and graduated in 2009. Dr. Clarence has had several certifications and belonged to so many different professional groups. He is a member of the German Association of Cardiothoracic Surgeons, and he is also a member of the European Association of Cardiothoracic Surgery. So Dr. Clarence has had so many publications in this field. He has actually also been, he's a philanthropist who really wants to do so much of humanitarian work in this domain in Cameroon, despite the challenges, but he's still very passionate that he's going to do a lot for his people back home. Here we are today with Dr. Clarence, who is going to be thrilling us with sustainable cardiac surgery in sub-Saharan Africa. And we will hear from him if we are getting there anytime soon. Dr. Clarence, thank you very much for accepting our invitation, and the floor is yours.
Thanks once more to the team of Cameroon Town Hall to be able to give this talk here. It's more of a health political talk than cardiac surgery. And when I heard about what Muno said about the COVID pandemic and the discrepancy between the rich and the poor countries, I saw a lot of similarities to cardiovascular diseases. So, I think you can see my slides now, right?
Yes.
Okay, good. So while preparing this talk, Muno asked me to first of all highlight, or he asked a lot of questions about what actually cardiac surgeons do. So I decided I'm going to give the first part of this just to explain what we actually do before actually delving into the problem. So cardiothoracic surgery, or cardiac surgeons are actually people who mend hearts. We repair hearts literally. And you'd see the heart is made up of valves and hearts, and has also blood vessels which could be occluded. And we practically repair what is spoiled in the heart. This is an example of a stenotic calcified aortic valve. And we excise it and repair it, like in this case, or replace it with biological prosthesis. Well, repairing valves is not only what we do. We also bypass occluded blood vessels, if you can see, in this case here with the vein, and sometimes with the arteries. And here is actually a video of our center of bypass surgery we did off pump. And you can see here the grafts which have been placed. Sometimes repairing the heart is not enough. So we could either change or transplant the heart completely, that's a spoiled vessel, or in this setting here, we could add some additional support like a pump. This is an assist device to assist the heart in its function. Good. Becoming a cardiac surgeon, I think most people, I heard again, I said, some people confuse it with cardiology. A presenter 2 weeks ago, or Dr. Chang Taka is a cardiologist, and that's very different from what we do. The training, in any case, here in Germany takes 6 years, and of this 6 years period, you have at least 4 years which you spend in the surgical ward. And during this period, you are required to do a certain number of cases, which with which you could take the specialist exams. 2 of the 6 years are spent to do what we call a common trunk. That's just basic cardiac surgery. And after having done your specialist exams, it's always advised to do some form of subspecialty. While talking to Muna too, Muna was always saying cardiothoracic surgeon, cardiothoracic surgeon, is because you would rarely see a cardiac surgeon who is a specialist just in one field. So we always, or most often than not, we combine either vascular surgery to cardiac surgery, or we combine thoracic surgery to cardiac surgery. Good. That's it. After having finished your training as a cardiac surgeon, you can't just get off and go and start working anywhere you want. In the best scenario, in the best setting of cases, you would need to have good cardiologists who could accompany you during the work. I always see it like a symbiosis, because there is no cardiac surgery without any proper running cardiology department. And the healthcare system should be built in such a way that the primary care physicians are alert and aware of the problems which could lead to heart failure. So these patients can be referred either for diagnostic evaluation or to specialists to be taken care of. And of course, the patients who are operated upon need to be taken care of. They need to be taken care of before, during surgery, after surgery, and sometimes during follow-up. And of course, there's no cardiac surgical care without actually the surgeon being in place. So, and building a cardiac surgical unit, you realize there's actually a lot of planning involved. There needs to be proper infrastructure, because the patients operated upon needed to be seen, as I've said before, before surgery, during surgery. You need to have proper equipped surgical wards, and after surgery, they need to be taken care of in a cardiac intensive care unit. Infrastructure is not only what is needed, you need trained and qualified personnel. In the best of cases, the European Union of Cardiothoracic Surgery put out a paper in 2016 describing the prerequisites of building an optimal cardiac surgical unit. And there they said you needed at least one senior cardiac surgeon. You could have a general surgeon, you need at least 2 cardiologists, you need somebody to be able to take care of the intensive care unit, you need nurses, perfusionists, and of course, you would also need accompanying specialties, because these cardiac surgical patients are most often than not only sick with their heart problems, and sometimes complications too could occur during surgery, which you will need maybe vascular surgeon or a general surgeon to salvage the situation. And of course, there's no, the people say cardiac surgery is high-end medicine. We are going to debate about that later on to see if it's actually high-end medicine. But you need proper equipment to be able to do appropriate diagnostic and to be able to follow up these patients after and during surgery. And if you have these equipments, definitely you need people to be able to take care of them. So in a nutshell, those are the different specialties one would need to have a proper and running cardiac surgical unit. And I'll just to tip it in, because there's no cardiac surgical unit which doesn't function like a team. So all of these people, if you are thinking of training and implementing cardiac surgery in any place in sub-Saharan Africa, then you need to think of training these guys as a team. So before we go forward, I would like you guys to participate in this quiz. I think I would launch it. We have tried it. I'll stop sharing. Ah, no, I can do it with the poll. We launch poll, and all of you who are logged in, would you please answer just the first question? We have 1 minute for that. And after that, then we are going to continue with the presentation. If you're true, you can just put a thumbs up so we will not have to wait for long. All those who have answered, just put your thumbs up. There is no correct or wrong answer. It's just to poll in opinion. Just the first question, please. 3 people, just the first question, please. We have 28 more people who are still waiting to answer. Let's just give it a minute. Okay. So we'll be rounding up soon. 27 more people.
I think this sets a base for our conversation at the end of the presentation. So please participate and answer. Just give your answer. There's no right or wrong answer.
Well, it's okay. I've just stopped it and I'll share the results. Here we have 70% of those who responded say it's absolutely necessary and should be addressed immediately. Well, we are going to see if you're correct or not. Okay, stop sharing. You can click it out of your screen. Okay. Now a little bit of psychology and sociology. Abraham Maslow was an American psychologist who described who made up this hierarchy of needs for humans. And he said you can't go up the pyramid if you haven't fulfilled the basic levels first. So you have basic things like food, water, and safety, love, belonging, and you need to have fulfilled the basic levels to be able to climb up to the next level. This functions also not only for individuals, but for communities as well. So you could just imagine at what level of hierarchy the Cameroonian society finds itself at the moment. So I'll just let that be and move on. The World Health Federation say we have about 39 million people living with rheumatic heart disease. But before rheumatic heart disease, I had said ahead before that when people talk about cardiac surgery, they think it's surgery for the rich people of affluence. And actually you have heart disease for rich people, and that's coronary heart disease. And there's the heart disease for poor people, and that's rheumatic heart disease. Because you have basic infections which go on to infect and destroy the heart valves. And you would see over 90% of those with rheumatic heart disease are found in low and middle income countries. And Cameroon or Sub-Saharan Africa finds itself in that range. You realize the population who is at risk, the younger population, you have most of them who are 40 years of age or low, and you see above 80% of these are really young people. And finally, besides medical treatment with proper antibiotics, surgery is like the end-line therapy for this rheumatic heart disease. Let's take a look at the population distribution in Cameroon. You would see over 90% of Cameroonians are below the age of 50. So Cameroon fits in directly into the risk profile of people who suffer from rheumatic heart disease. And Cameroon is among the 50 poorest countries in the world, with a per capita income of approximately 1,500 euros. So we are gradually getting there, realizing cardiac surgery or cardiovascular problems is a problem in Cameroon. I just think this COVID pandemic has come and dampened the avalanche which is rolling towards Africa. This is another information from the World Health Organization. They say approximately 17 million people die of cardiovascular disease worldwide. And you need to guess twice where the majority of these people are found, in low and middle income countries. You have more than 80% of those dying of cardiovascular diseases found in low and medium income countries. This is partly due to the fact that they have poor access to medical facilities. And even if they do have the access to the medical facilities, it cannot be easily financed. And sometimes I have the idea the government doesn't see that like a priority because they think we're dealing with other tropical diseases like malaria, typhoid, and they're thinking that's that should be the main focus. But I think for all of those who are in this forum now, at least you know one or two persons who suffer from, who has a cardiovascular risk factor, that's either high blood pressure, diabetes, obese, feeding, alcohol consumption. So, and that's why you would have this, I think the biggest associations in the world, that's the European Association of Cardiothoracic Surgery, the American Association of Cardiothoracic Surgery, the Asian Association of Cardiothoracic Surgery. You realize there is no African Association for Cardiothoracic Surgery. That's how important it is for Africans. These big associations have created an entire alliance to help solve these problems in low and medium income countries. And they were gearing up towards starting up the project before the COVID pandemic started. And their intention is to get down a senior cardiac surgeon on the ground to build and get a cardiac center running. And this is going to be financed by the World Health Organization and these different communities. So you have the idea, others are realizing this is a problem Africa is going to face at least in the next 10 to 15 years. Good, then let's get into the next quiz. I'm going to share the quiz again. Polling, and this time, please, you answer just the second question. What is the best way to solve this pending problem as we have seen in sub-Saharan Africa or in Africa as a whole? Do you guys think it could be solved through humanitarian surgery with voluntary aid or expatriate missions, or actually building local teams to have a sustainable running project in these regions? As I said, there is no wrong answer. This is just like a base for us to have a discussion with her. Okay, almost everybody has. Okay, then I would end the poll now and share the results. Okay, almost everybody says building and training local teams should be the solution. Well, let's see if that's going to be that easy. Okay, so and while going through literature, I think I found out three main models which I could coin down to be able to explain how the problem is trying to be solved in Africa. You have this Ghanaian-German model. I'm calling the Ghanaian-German model because the main advocate is Professor Frimpong. Professor Frimpong finished his medical studies in Ghana and later on moved on to Germany, to Hanover, to do postgraduate studies in cardiothoracic surgery. Later on, he moved back to create the only cardiothoracic, not the only, one of the first cardiothoracic centers in Ghana. You would see here they're celebrating their 20th anniversary. This center was created in 1989, and Professor Frimpong took about 9 years to convince the then president, that's Jerry Rawlings, to be able to give the permit for him to start this project in Ghana. And while the project started, he incurred the loans personally. That's according to what he says, the Ghanaian government did not spend any money to start up this project, and got this project running and independent. And they're actually, till a few years back, they were the only center who was certified to train cardiothoracic surgeons in West Africa. Well, this is a model which is flawed, and in part because Professor Frimpong had to take on a lot of sacrifices, personal sacrifice, to be able to build this. This system was partly integrated in the health system in Ghana. We're going to realize that's a problem, because building a cardiothoracic surgical unit needs to be properly integrated in the health system of the country. And the government needs to have a political will to implement this system. This is a similar model which has been implemented in Kenya. But in Kenya, the government was willing. They integrated this system into their healthcare program, and they paid a senior cardiac surgeon to come on the ground and build and train cardiac surgeons, and to build up the program and get the program running. So that's model one. The second model is what I think almost all of us we know, that's I'll call it medical tourism. And you have this, this is a similar case. People send out their relatives to get operated in South Africa or India, and if there are any problem, and the physicians sending these patients out get incentives for sending the patients out. So even their own local cardiothoracic or cardiac surgical units run dry because they lack the experience, and all the patients are being sent abroad. Well, this is a system which I think too is flawed, because it's only for those who can afford it. The poor and sick people who get these infections, which later on lead to rheumatic heart disease, most of them can't afford this care. So this is a model which is currently a part of the solution in Africa. Then you have the third model. I'm going to put these two, whereas I'm going to explain about the Shison model later on. You call it humanitarian surgery. And humanitarian surgery is where you have expatriates coming in from nations to the country. And these expatriates come in and perform surgery and try to train the local personnel. This is a model which is not integrated in the health system of the country. And it takes at least 10 to 15 years to get this system running and independent. That's with trained personnel. I'm going to take the Shison model is kind of like a combination of this. I'm being a little bit biased because I think this is the model which is most promising, which could have been most promising. In Shison, we already had a running health center with all the disciplines which are stated above, disciplines besides. You had an ICU bed, you had a resident cardiac surgeon, you had 2 cardiologists on the ground, and according to their data, they also had a cardiac anesthesiologist on the ground. So, I think the main flaw of this system was in part that it wasn't fully integrated into the health system. It was privately run by the tertiary sisters, and the location, because it was very difficult to access this center in Shison. And I remember as I visited the center, you would see at the time of the visit, their intensive care unit was newer and more modern than our center in Germany at the time. But unfortunately, as you would see, these prices are just an estimate. I'm not very sure. So if I stand to be corrected if someone says they are wrong. But these are the approximate prices you had to pay for full treatment in this center. because you know you have qualified personnel, this personnel needs to be paid. And we know what the per capita income in Cameroon is, and you can imagine if this is affordable then for the local population. That said, what needs to be in place to create a proper and running cardiac surgical unit? You need finance, you need inflow of money, be it from NGOs or the government or private. You need a proper healthcare system, and these cardiac surgical procedures need to be integrated into the running health system in the country. That's the primary care physicians need to be aware of the problem. They need to be properly trained cardiologists on the ground to refer these patients to the centers for proper treatment. And another aspect for this very expensive form of surgery is how affordable it is. You have in Rwanda at the moment a national insurance policy. This may be something which other African countries will need to adapt to make such treatment affordable for the general population. And last but not the least, and the most important, we need the political will. The government needs to realize that this is a pending problem or an impending problem, and they need to get active. We can't wait just like we did and get overruled like we are being done now with the COVID pandemic. We need to get proactive. We need to try to get institutions in place to solve this problem, which will come. So we have government policies, and if you have a cardiac surgical unit functioning, to have a certain degree of security and experience, we need a certain amount of workload. You can't have a cardiac surgical program where you operate just 100 people a year. That's not enough for the kind of expertise you would need. So you need to train those on the ground, and you need to get a proper program running. And of course, would benefit then from all the experts which we have here, and which we are seeing now in the Cameroon Town Hall, if they could chip in their opinion to get such programs running. So finally, I'll conclude. I think we had the discussion with Mona before. I think small steps matter, and we've already started now with informing ourselves about the impending problems in Cameroon. And we could start by fixing the small problems which we have on the ground at our different levels. And maybe in some time in the future, with the collaboration of some of the doctors here, we'll be able to get something good and running back in our hometown in Cameroon. Thanks for your attention.
Wow. Thank you very much. Thank you so much for this wonderful presentation. I mean, you've ignited a flame, and I'm sure you should have enough fire extinguisher to put out the flame, because you just open our eyes to so much of what maybe we do not know about how important the field of cardiac surgery is, and how much deficiency we might have, or whatever progress we might have made as far as Cameroon is concerned. Thank you very much for this wonderful presentation. And we are going to open the floor to questions. And before we start, I would want to just open the floor with this question to you. And you presented the different models for cardiac surgery. And one of the models that caught my attention is the medical tourism model. And Rwanda was mentioned, and India was mentioned. Rwanda is in Africa. And I was wondering, there was a time we heard about Mercy Ship in Cameroon, where a ship comes and harbor and people go there to get treatment for a particular health condition. If you were to suggest to Cameroon a model that works, that could be sustainable at the present situation that we have in our country, will you think that Cameroon should prepare itself to be another Rwanda? Or will you think that we should start from a bottom-top approach where we have to start solving the problem from the root source and training expertise and building our own system that can be sustainable on its own?
Okay, thanks for the question. I think Cameroon doesn't lack experts in this field. We have enough cardiac surgeons to be able to get the program running. We have enough cardiologists, and we have enough anesthesiologists around the world, not in the country. And I've been in touch with most of these people I'm talking about, and they are willing to get a program running in Cameroon. What I think is lacking in Cameroon is the political will. So one has to be careful if how you express this, but I think this should be seen by the government or the policymakers as an important problem in Cameroon. If the government should realize that this is a pertinent problem, I think infrastructure and personnel is not going to be a problem. If you look at Chisholm, they got their training in part through missions. That's, of course, they sent out 2 cardiologists for training who finally came back, and there was also a resident cardiac surgeon. But the rest of the team, the nurses, the perfusionists, the scrub nurses, they were in part already people who were already available on the ground. And such hospitals, you have them too in Cameroon. I think 2012, there was a similar project in Douala where the Belgians came for a mission to perform cardiac surgery in the general hospital in Douala. And they reported having operated, I think, 45 patients at the time. So personnel and qualification infrastructure is available. I think financially, it should be possible in Cameroon. Where we'll have a big question mark is the political will.
Thank you very much. And I'm glad you mentioned that we have all kinds of experts in Cameroon, and this is true. And sometimes what really bothers us is whether, in terms of healthcare planning, and you have a master's degree in health business administration.
Correction, I'm doing the master's program. So.
Oh, you're doing the master's program. You will have it because you've had better degrees than that, and I think you're going to make it. When you look at the health map of Cameroon and you look at the way the health infrastructure is being geographically spread, then one will question that if you have a very big referral hospital in Sangmalima, that is not up to 100 kilometers away from another referral hospital in Yaoundé, and you have a very big cardiac hospital like the one in Chisholm, then one will wonder why accessibility should be a problem. That is not your question because you are not a politician. But the question I want to ask, and I will be bringing Nje Basil in here, who is one of the doctors that have recently been honored in the United States as some of the most recognized doctors in America. You and Basil are experts in very special fields that we have, that are rare for people to specialize in. Do you think that Cameroonians, private sector, let's take, for example, you who are not working with government, you are not politician, can we in any way solve this problem without waiting on government? Is there a way the private sector can take over the healthcare business in Cameroon?
Is the question directed to me or to
Basil, and then you?
Let me talk a little bit because I have to actually run. I'm actually on call.
First of all, congratulations for your recognition.
Thanks a lot. Thanks a lot. By the way, excellent presentation. I really enjoyed it and I learned a lot. I think with regards to the question, I think there's a lot the private sector can do, but the private sector cannot do so much if the government is not interested, So the government can actually interfere with a lot of things the private sector wants to do. I know there's a lot of work being done by the mission. So I'm talking about the Baptist mission, the Catholic mission and all the like. So I think Shisong is Catholic, right? And then BBH is Baptist. And with regards to GI, gastroenterology and hepatology, a lot of the research that is coming out of Cameroon is actually from the Baptist Mission. You know, they have a large part of patients with chronic hepatitis B, and they have been able to do a lot of research, and they actually have a big grant, an NIH grant, an RON grant of about $5 million through the Baptist Mission. So there's a lot you can do, you know, bring in funding, see patients. But if the government is not interested as well, there's a group of patients who would not have access to that care, and you need the government to kind of step in. You know, government policy also prevents you from doing stuff. For example, there's a lot of people who want to send medical equipment into the country. You know, I mean, you know, taxes are a problem, things like that. And so if the government is not able to put in protocols in place to facilitate people from, you know, either importing equipment or even setting up a hospital, that could actually limit the private sector. And I could go on. And so there are a lot of things. I believe that, you know, we don't get enough support, you know, in the diaspora. I don't think we get enough support. And I think that the government can do a lot more. I'm sorry, that's my call.
Thank you. You have to go and take care of your patient. Love you so much. And,
all right.
I look forward to see you here. Thank you so much. And
thank you. I appreciate it.
Back to you, Clarence. You mentioned, and the first series of questions will be from the moderator. I will soon be handing over to Brian and to Christelle to ask their question before we see some hands off. Just permit the moderators to grill our presenter a little bit. Now, you mentioned that 17.5 million, 39 million people live with romantic heart disease around the world. And you also said this is disease of the poor. And if this is disease of the poor, and one of the major interventions for romantic heart disease is cardiac surgery, how can these bills be paid? 94% of payment for healthcare in Cameroon is out-of-pocket payment. We don't have a general insurance policy like in Rwanda, as was mentioned, where, you know, insurance can cover the cost of care. If we have a country where 94% of payment for healthcare is out of pocket, and where an average, you know, people still live on less than $1 per day in certain parts of the country, should cardiac surgery be part of a social insurance policy supported kind of intervention, or should it still be a kind of a payment system intervention where citizens who are sick of cardiac problem should pay?
Well, I think it should be part of a health care insurance system policy, but the government should try to work towards prevention. We shouldn't wait till when the patients are already sick and need the expensive cardiac surgical procedures. We could do a lot to reduce the cost for the country, for the public, in doing adequate prevention, taking adequate prevention measures before. And adequate prevention measures can be taken to if you have only trained and alert personnel on the ground. So I don't know how the medical doctors are being paid in Cameroon and how motivated they are doing these works also in the rural areas where, as you say, the people live for with less than $1 a day. But this should be a campaign led by the government. And of course, part of our medical system in Cameroon is being financed by the World Health Organization, I think. It's in part too for the Cameroonian government to make these associations understand that it's an important, it's something important which they have to do in Cameroon. That's taking care of cardiovascular medicine. And this insurance policy too could be covered by these international World Health Organizations. So I think it's, to make it accessible for everybody, you need to get it supplemented.
Thank you for that response. And I really agree with you that there need to be, you've emphasized on political will, and that is very important. And of course, the Minister of Public Health will soon be on the Cameroon Town Hall for Healthcare Professionals, and everything is still being worked out for its availability. And I hope that presentations like this, I should let you know that it's not just for fancy. it goes really wide and it reaches really far and wide. It goes really beyond where you cannot imagine. And that's why we are happy that you accept our invitation, because there are people that are going to watch this video and they would understand how important they should prioritize cardiac surgery in Cameroon. I hand over to my co-presenter, Brian. Brian, you have some questions for Dr. Clarence.
Dr. Clarence, really great presentation, excellent presentation, straight to the point, direct, not complicated. Really appreciated that. Really wonderful presentation. I think that when we have in this conversation, when I was reading about this topic, this subject in general, just trying to get clarity on the sustainability of cardiac surgery in Africa in general, not just in Cameroon, I was really shocked to see the ratio. I was reading one paper in the Lancet that talked about the ratio between the number of cardiac surgeries per the number of inhabitants. And they were like, I think 1 cardiac surgery per 33 million inhabitants in Africa. So it's a really, I think it's a really, really huge problem. My question is, Elvis mentioned about political will and really having the government, taking ownership of this problem and that. But do you think that we're really generating sufficient, data to like drive some of these decisions? Do we know about the problematic of just rheumatic heart disease, for instance? Do we really have a really great surveillance system for the diseases that would definitely ultimately lead to cardiac interventions, like rheumatic disease, congenital heart disease? Do you think we have really good surveillance mechanisms in place to track that? Because that's really what's going to, if I'm the Minister of Health or I'm the President of a country, definitely those kinds of data sources, those data points would definitely be one of those key metrics, really, for me to want to invest billions and billions into that. I think just wanted to hear your thoughts around that.
First of all, as concerns information in Cameroon is a black hole. I think Africa as a general is a black hole as concerns cardiovascular surgery. There are very few papers with presentation, with data on cardiac surgery in Africa. And of course, most of these, and most of them are published by the expatriate humanitarian surgical groups who come to do surgery in Africa. And the data they present, over 90% of the patients they operate upon, where if they are not pediatric cases, have rheumatic heart problems. Okay. Now you're talking about the Minister of Health not being able to address this problem because there's no data. You can't, as Taka was saying last time, you can't see a problem if you haven't analyzed it. So there are a good number of people who die at home. There are a good number of people who get sick, have heart problems, suffer with the heart problems, and die and never get diagnosed. We have no proper diagnostic equipment or material back home in Cameroon to be able to say, okay, this person is suffering from this problem or that problem. That's lacking. So we can't even gather the data that is needed to be able to convince the minister if that's what may be needed for him to implement such a program. I'm going to go back because I stated too that Professor Frimpong struggled and implemented this cardiac surgical unit in Ghana. You would imagine the first open heart surgery in Germany, I think, was in 1958. The first open heart surgery in Ghana was in 1964. But now you can't compare the gap there is between cardiac surgery in Germany and cardiac surgery in Ghana. Of course, there was political instability and there was a lot of uprising, but Professor Frimpong came back, and in 1981, that was the first time he spoke about it to the government, saying, oh, we need a cardiac surgical unit up and running in Ghana. Succeeded to lay the first brick in 1989. So we can't do anything if the government is not reading. We can't do anything if the government doesn't realize that cardiovascular disease is a problem. So of course, we could talk about all the models and all the possibilities, but the government is a big player and it needs to be involved. Yeah.
Good. And Brian, we have Dr. Taka here in the house, and also Dr. Taka is an interventional cardiologist, and Dr. Sostani is also a cardiologist here in the United States. And the question will be, so if Dr. Clarence, Dr. Taka, and Dr. Sostani all put their heads together and say, we want to open a cardiac surgery, a center for cardiac surgery in, but maybe in Moliko, for example, where do you think the hindrance what will be the major hindrance? Will it be the fact that there are no anesthesiologists, or there are no nurses, or maybe that we don't have, because you mentioned in your presentation that we need infrastructure, we need trained and qualified personnel, as well as we need equipment. So if three of you who are experts in this field decides to be entrepreneurs and to also pay attention to the small number of people who can pay out of pocket, because of course, we should not sacrifice the rich because the poor cannot pay. If you decide to go into business and to open a cardiac center in Moliko, what do you think will be your major obstacle? Let me start with Dr. Taka before Dr. Sostani comes in, and then of course, Clarence, you will wrap up.
Yeah, thank you, Darcy. Yeah, Clarence, that was an excellent presentation. Thank you so much. I learned a lot. Before I answer that question, I just wanted to address a few things. I know most of the things you mentioned already, I just want to highlight them. When we're talking earlier, I raised the point of getting these patients who have these cardiac pathologies to the cardiac surgeon. The cardiac surgeon is sort of at the peak, and at the ground level, we have to be able to diagnose these patients in the first place. So imagine a kid who is born somewhere in the village having a congenital heart problem. Most of these kids go their entire life and they have no clue. I mean, ask yourself how many Cameroonians get a cardiac echo in their life. It's probably less than 1%. So how on earth do you expect this diagnosis to be made in the first place? If you're fortunate enough and you're in Yaoundé and you get to see a cardiologist, and then you get an echo, then they say, oh, wow, you have mitral valve disease. You need to have it severe. You need to see a cardiac surgeon. You need to get surgery. But if you're not, and that is, again, that's less than 1% of the population, So I think in order to get the volume needed to maintain good cardiac skills as a surgeon, you need to not only create the cardiac surgery team itself, but you need to be able to feed this team with a steady supply of patients in order for them to become a center of excellence. So you need to do a minimum number of these procedures every year. So I think it's as important to train this team as it is to train the system in order to identify and diagnose these pathologies in order to refer them appropriately. I think that's very important. So I know Clarence talked about this at the beginning. The cardiothoracic team, surgical team cannot function alone. The entire system has to be aware that this team is available, and we need to make it possible to actually diagnose patients and guide them towards the centers. Now, having said that, I think yes, I think we'd have to probably do baby steps. We have to get all the people who are qualified to start such a program. But at the same time, we have to start. I mean, obviously with the government involved, but we have to start training other doctors, right? We know how the healthcare system in Cameroon is set up. We would have to go down to the district level, talk to those people, tell them, hey, if you see a patient with shortness of breath, it's not only about doing a chest x-ray. There are other things that could be involved. Simple things like listening to heart sounds can go a long way. So if you think about it, there's a lot of work that needs to be done even at the ground level to identify these patients in the first place in order for that cardiothoracic surgical team at the top to function. That's my 5 cents.
And Dr. Sostani? You're welcome.
Thank you, Chief. Clarence, that was a good presentation. I didn't follow up everything. I just logged in late. But maybe some things I'll say will be redundant because you've already addressed them. And Taka talked about trying to gather these patients. I think I'll focus on infrastructure. I think what Clarence does as CT surgery requires a lot of specialization from what I understand. And even in very robust systems like systems that don't have a good infrastructure surrounding the CT surgeon don't survive. He comes in with Clarence will come in with all of these skills, but he will also need a lot of people around him as associate providers. We mentioned the nurses, anesthesiologists, a big team, which will work with him to make a program established in a system like Cameroon to survive. If those people are not there, I will not expect him to do the surgery and to follow up all of these patients overnight by himself. And those are some of the factors that had led to failure of some CT surgery programs in a lot of places that gave them a lot of mortality. And so infrastructure to me will be something which our system will want to invest into. Knowledge building, capacity building of identifying these patients and bringing a big team behind a CT surgeon to take care of these patients who are needed. We cardiologists, we rely a lot on I'm sure Taka knows, we rely a lot on CT surgery for everything we do because they are our backup. So even for us to survive, to do a lot of complex things, we require them to be even at a phone call away to help us if things go south. So I think in a system like Cameroon, knowledge-wise to infrastructure, to knowledge-wise to understand the problem, to diagnose the problem, to bring these patients to the surgeon, and to give the surgeon the resources he needs. Not just building a building and putting an OR in it, but all the resources he needs to succeed so that the patients he takes care of can walk out of the hospital after that.
Yeah. Thank you very much. And Clarence, now.
Let me just make it short. While Taka and Sustain have spoken about infrastructure and the need for proper diagnostics, I'm going to say all of us, none of us are in Cameroon at the moment. So we can't go to Moliko and just start operating. So we need to, someone needs to be on the ground to check these patients and say, okay, you need surgery or you need intervention for the interventional cardiologist. So we would need to have someone on the ground. It's kind of like, it's just like marketing. Let me put it in quotes, it's a business and you need lobby. You have cardiologists in Cameroon. These cardiologists get to see patients in Douala and Yaoundé. You need to get to know these guys. And these guys need to be willing to refer the patients to you in Moliko or wherever you are. Now we have the tourism aspect of it. The guys in India and South Africa, they give incentives to these doctors to refer the patients to them for surgery. Sustain, Taka and I are not going to be able to have that money to pay these guys in Douala and Yaoundé to be able to refer the patients to us in Moliko. So that's already a problem. And I'm thinking building a cardiac surgical unit, it needs to be integrated in the universities, in the medical faculties in Cameroon, because that's where you start creating awareness. So, and that's where you even start giving the fundamentals of what you're doing to the students in Cameroon at the time. So if any of you are thinking about it, it shouldn't just be in the hospital. We should be present too in the teaching systems in Cameroon, that's in the universities in Buea, in Yaoundé, to start already, as you say, giving with the baby steps, teaching these students what cardiothoracic or cardiovascular medicine is all about. Yeah. So that would be the approach if I would have to decide. Yeah.
Thank you very much for tactfully answering these questions. I really appreciate you, Dr. Sostani and Dr. Taka, for coming in. I'll pass over to Christelle to ask her question. Then we will open the floor to the audience for general questions to our presenter. Christelle, over to you.
Merci Elvis de me passer la parole. Merci Dr. Clarence, c'était une très belle présentation. Please permit me to speak in French.
Okay.
So, c'était une très belle présentation. Moi, le point qui a attiré mon attention, c'est le dernier, notamment des baby steps, little by little, parce que prendre soin, faire une chirurgie cardio-thoracique, c'est très important, mais il faut suivre le malade, le chirurgien ne peut pas le faire. Et ma question, une part a été déjà adressée par Dr. Taka et par vous aussi, comme quoi je voulais savoir qu'est-ce qu'il faut faire de manière pratique pour améliorer des baby steps. Par exemple, vous avez mentionné la performance et tout récemment, vous avez parlé de l'éducation, notamment installer un système de chirurgie thoracique dans une université où déjà les étudiants seront familiers avec la technique. Et Dr. Taka parlait d'améliorer le diagnostic, notamment pas seulement faire une radio thoracique, mais l'auscultation cardiaque. Mais est-ce qu'il y a d'autres éléments qu'on peut faire de manière progressive en attendant que tout le système se mette en place, mais déjà qu'on améliore à la base ce qui est nécessaire? Merci beaucoup.
Well, thanks for the question. I think at the moment, what we could do is mostly going to be voluntary. That's either the experts in this field are going to have to visit Cameroon on their own expenses and try to create awareness on this topic on the ground. On another note, it's also possible for these NGOs who are coming into Cameroon for mission programs to create opportunities for the local personnel to go out and get this expertise. I think that's the case in Douala. I think there were a group of surgeons who went out for cardiac surgical training. And I think that was the case too in Chisholm, where they trained their cardiologists abroad and they came back and had to implement these systems on the ground. But I'm still going to summarize, the government has and needs to be involved. Yeah.
Great. Thank you very much. And now it's the time for the chair. Dr. Muno, I know your questions, you cannot say you don't have a question, then I'll just off the microphone and shut the program off. Now it's time for you to come ask your questions to our guest. We're always excited to get your questions.
I just wanted to, how do we do to sustainably keep these guys in Cameroon, Clarence? You know, for the past years, I worked in Cameroon and there have been efforts to train personnel, but the problem has been retaining them. So I can recall back in 2008, the government sent both nurse anesthesists and anesthesiologists back to France and Belgium with some young surgeons to France and Belgium to train as cardiothoracic nurse doctors. And the best of my knowledge is that 80% of them stayed and didn't come back to the system. And we realized that there was a lot of how do I call it, brain drainage, which we are all here too, is part of the whole thing. So how does the government, I think you nailed it, your presentation was extremely straight to point, nailed a lot of the facts that are hindering this, the practice of complex medicine back home in itself, I just want to call it that way, and the practice of any medicine other than infectious disease-oriented tropical medicine back home. The government has not prioritized it. The government has not seen this to be a problem. Human resource is not well taken care of. How do we take care of human resource to even retain them? Infrastructure is built, but not sustained. meaning CHU in Yaoundé was at the same level as CHU of Bordeaux. They were building the same infrastructure, but if you look at the two of them today, they are two, there's night and day. As you said, also, the Shishong, when you looked at the Shishong, the time you went there, the ICU was as good as your ICU, but today, where is it? How is sustainability over time? I think we live in a system where really there is a problem with human resource, there's a problem with sustainability, there's a problem with accountability. And mine is not really a question, just a reflection to the whole town hall, really to think about it. Even if we go around training these people, are we going to be able to even retain them? Are we going to be able to open a center that is going to be functional? And so that's just my reflection, my first reflection.
And Mono, before Dr. Clarence comes in, my question, have you thought about how Shishong has been able to retain the surgeons that are working there up to today?
So I would tell you that the model in Shishong is working, but it's not working perfectly. And I don't want to go into the details of that model. Even trying to collaborate with Shishong can be a big problem. Trying to sustain the number of patients they're having. At times they have backup of patients who cannot get surgery because the particular surgeons are not able to be there. The Cameroonians that they have actually trained right now because of the political crisis, I'm sure they are not able to do any surgery at the moment. That is politically oriented, but there are other things too. So that model in itself, as Clarence said, he has more details in understanding the model, but I don't think that's a great model. It's a great model that can work if it was integrated into the healthcare system or a teaching hospital, where you're able to train young doctors to fit the system and to even love cardiac surgery to the point where they can train as residents. So if Shishong had a training medical institution attached to this, it would have had a model that would always fit the Shishong Cardiac Center with cardiothoracic surgeons, cardiac surgeons, vascular surgeons that are going, and cardiologists and interventional cardiologists that will be able to do procedures that would help these patients, and also pediatric cardiologists. So this is really a model that was created, but I think the Shishong model needed help from the government. They needed sustainability. They needed to be open to collaboration, which they are not. I'm sorry to say that, but I have nothing to lose, but I really want to say that at times, the mission at times is good, but there are days they are it's not a model I support a lot, and I'm very vocal about things I don't support. So the mission is good, but at times they feel they are the best and they don't want to get help, or they feel that help coming to them may come around and attack the infrastructure they have put in place. They should be more open in order for them to be more sustainable and develop over time.
Yes, thank you very much, Dr. Mono. And I agree with you that they need support from government. And you remember that the Catholic Mission wanted to open a medical school, and there was a big debate with the government. And I think their program was shut down when their students were already in the second or third year of the program. So there's a lot of political issues that we cannot actually go deep into the town hall to discuss these issues, but it's an eye-opener that we should know the different root causes of why things are not working the way they are supposed to work. At this time, we have Dr. Crispo and Diabamo, whose hands has been up. It's time for you to ask your question while we get the rest of the members of the audience to prepare to ask questions to Dr. Clarence.
Hi, great. Thank you very much, Dr. Clarence, for your great presentation. I like it. It really pinpoints out details of what we suffer in our system. But I have a two-pronged question. The first one is just to reiterate to say that sometimes these missions do reject the help from government, especially in our settings, because we know, I mean, this is not, I don't know how to say this, but I just want to say that we know that generally when this government comes and offers a help, even if it's a 1%, 99% of the time they would use it to make political gains, to transform into other things. So these guys, once bitten, twice shy. I mean, we can't keep saying that we will just, so they have their strong reasons for always rejecting the government for wanting to support, because a majority of the time, and we've seen it ourselves, when a government comes to intervene in something like that, it's going to be in the next few years like, oh, we did it, we did everything, and they want to use it for other again. So maybe that's why they always they want to reject it. But then also I want to ask this question about, I know it's a little bit sensitive, but in terms of our complex, in terms of our nature, of our thinking, those who are trained as specialists as a whole, when someone is trained, for instance, you come here to Tokyo and you train as a thoracic surgeon, and then you go back to Cameroon, how do you behave? I mean, we've seen this. I just want to understand how, because I have like a concrete example. I remember when I was going through med school there in Yaoundé with when one of our professors, I'm not sure if I want to call the name here, but when she came back as a thoracic surgeon, it was more chaotic than, what the system was, just you don't want to collaborate. I know, yeah, we don't do really good things back there, but still just collaborating with local people and trying to help them where they're wrong, it's better. Sometimes the complex of the doctors that come back and get rejected by the system is so damn terrible. So I just want to ask, what is also this problem of our complex? Is it complex of superiority because we think, oh, we went out, we got training in a cutting edge technology setting, and then we come back, we're in a crap or bullshit kind of setting. So, oh yeah, we know everything, and every other person saying anything is crap. Also, the system doesn't take them well. System is always like, yo, you're coming here, yeah, you just want to come and take a position, be the head of service. We don't want that. And the fight starts from there. How can we solve that kind of interaction? Because I think it's one of the things that make sometimes when we even think of going back there, when you come, you are like, oh, how am I going to be received? First of all, because if you are not received home, then how can you try to help home? So I'd like you to talk a little bit about this complex that we have as human behavior, first of all, and how we kind of fight each other. And even generally, from my little experience traveling around the world, I generally see that people who come from settings as ours, they have a hard time collaborating together, even out here. I just want to understand that. How can we solve that as doctors? Yeah, thank you. I'll stop here.
Right, it's a very complex question, which I think we would have to discuss for a long period of time in order to answer it extensively. Well, the first, I think, is to realize why you're doing medicine at all. We are service providers. We provide service. And if you should be in that humbling position to realize you're there to serve the people, then you can't be arrogant. You can't be like the God who is coming to solve the problem. I think that's the point of view, both of those returning and in part of those who are on the ground. Because of course, everybody is fighting for their position and you don't want to give up your position. The second thing about those of us being out here is who don't want to collaborate is, unfortunately, for the Black man, I don't know why, I'm just saying that's my guess. In whatever field we are in, sometimes we have the idea it's a rat race where the winner takes it all. And there is a spot for just one person at the top. And you can't imagine a situation where you be a cardiac, for example, a cardiac surgeon, and you say, oh, this is my brother here, my sister there, and you come, let's work together. In sort of a way, it's kind of like a more impeded, or really strong in our heads, Africans. I don't know if it has to do with slavery and stuff like that. I don't really know. But where if you meet a Black man top at any position, true, he wants to remain special. He wants to be the only Black man at that position who has ever done this and that. Well, I think it's a training problem, and it's something which would have to change. Seeing the way we are collaborating now in the town hall, I think in our generation, it's more or less present. I'm just going to answer one, just to comment on what Muna said about what do you do to keep the experts who go out for training? Because that's an important point, because even this lady coming back like a trained thoracic surgeon, it's not everybody who does that. And of course, man cannot live on bread and water alone. Sometimes you have a family, you have running costs which you need to take care of, and you should be able to finance all of that. So in part, for example, I'm just going to give an example of what I know. In Germany, if you should decide to go back to your country, there is a system in place where the government covers your salary, at least for the first 2 to 5 years, the same salary you should have been receiving in Germany back home. That's to encourage all those who come for training to be able to go back and implement, or being able to start off back home in their local countries. And I think maybe these guys, giving the possibility for these expatriates to go to Belgium or to France for training, they need to think a little bit further to say, okay, if these guys go back, and of course they're going to see the standard of life where they are, we should be able to offer them some financial support to say, okay, you'd have to go back home and we're going to cover your finances maybe for the first 2 or 3 years while you're on the ground. That may be an incentive to send these guys back home.
Clarence, can I follow up with a question, please? Yeah. Now, this is a question. So one of the big problems we've had and frustration in medicine has been among physicians who, let's say, are cardiothoracic surgeons, finding themselves back home in association with others who call themselves cardiothoracic surgeons, but you're unable to justify if they are surgeons or not, and if they are qualified or not. There is the whole aspect of charlatans that have infiltrated every field of medicine. Medical doctors know about it. They don't talk about it, but it's something that everyone knows, that among every big specialty fields, there are people who went to Europe and did 1 or 2 weeks of training. Others went and did some few months of training, came back home. They have never done any surgery. They call themselves, let's say, I'm a cardiac surgeon. The other one says, I'm a vascular surgeon. The other one says, I'm an oncology surgeon. The other one says, I'm an oncologist. And this leads to resentment in itself. And this leads to lack of collaboration among those who are even there. So what is your take about this aspect? I know a lot of people are going to react. It's something no one wants to talk about, but everyone knows about it in some, because we do have the medical society that doesn't really verify the certificates in a lot of cases. And we know people who went and did stash in hospitals for months. They never touched patients. They did internships. They did observerships, but today they are calling themselves cardiothoracic surgeon. They have never operated anyone. And
yeah, Muna, I think it's a structural problem. That's why you have, in America, for example, certified registered nurses and stuff like that, or certified cardiologists. And you have associations who make sure, and it is in their best interest, that those who are certified are appropriately trained. There is no way on earth you could be a cardiac surgeon after 2 years. Never, ever. Never, and not even after 2 weeks. Speak less of 2 weeks. And even finishing training doesn't mean you are experienced enough. You need a certain number of years of continuous training to be able to attain a certain degree of expertise that you can say, okay, now I feel safe to swim alone. That's one thing. And so in Cameroon, if you don't have a board, I don't know if there's a board of certified surgeons, a board of certified, let me say maybe gynecologists, because how then do you get the title as a gynecologist in Cameroon, for example?
Oh, okay. In that
Do you
case,
take an exam? Do you have a certificate? Is it certified? Are there, for example, in Europe and America, I think there are a certain number of cases you would have to have done, written, documented for you to be able to take the exams as a certified cardiac surgeon, for example. Are such curricula in place in Cameroon? So if Cameroon doesn't have even this basic curricula, training curricula for the different specialties, it's going to be difficult to solve this problem. You can't then go to this person and say, ah, my brother, you have been abroad just for 2 weeks. There's no way you can be a neurosurgeon, for example, or a cardiac surgeon.
Yeah. So I think this problem, we don't have it in the basic surgery programs, internal medicine, because we do have people we're training. Now, what do we do in situations where we do not have this in subspecialties and advanced specialties that are all done out of the country? So there is really no board that I know of that actually verifies this. The medical board is supposed to get a standardized method of actually knowing who is well-trained and who is not. But this is a systemic problem where we have people who are saying they are what they are not. So which actually leads to the resentment you find among people in the specialty themselves, not knowing whom to trust and whom not to trust.
Yes, and they always say that where ignorance is bliss is folly to be wise. And sometimes if you say you're a cardiovascular surgeon in a situation where there is no infrastructure for you to perform surgery, you are lucky because you can do that for 30 years. Nobody will catch you because there will be no surgical situation where you are called up to perform that will actually disprove you. So they are safe by doing that because they don't have what it takes for them to practice. But I think like you said, we don't have this professional association that have been legally, mandated through parliament to exist as a body that can actually certify these professional groups. And so in the absence of that, we just dealing with what we have is supposed to be the Order of Cameroon, the National Order of Physicians, which is supposed to do really much work to ensure that they actually get accreditations and verification of accreditations when people come back home after study abroad. And we also know that the Ministry of Higher Education has a very, very, I can say, inefficient way of verifying credentials from abroad. If you have studied abroad and you go to verify your credentials, it might take 2 years for them to verify and nothing is coming up as a result of that. And so it takes quite so much effort to know who is who. But I think our conversation here should be about also seeing how can we as professionals be able to filter these people out and because if you say everybody knows about it and nobody talks about it, then I just remember whenever I'm in the New York subway, they say, if you see something, say something. That's a normal slogan in the subway that the police actually announce. If you see something, say something. And if we cannot say something, then we are actually part of the problem. And I think that we as professionals should start a way of denouncing these kinds of self-acclaimed professionals because they put the lives of our patients at risk. It will be very useless for you to think that there is a cardiovascular surgeon in a hospital and you refer a patient there just for him to do nothing under the auspice that maybe there is no infrastructure, but because the person is actually not the professional. So it's really a serious problem. We can be thinking about methods of how to denounce these kinds of issues, platforms through which we can do whistleblowing without identification, anonymous whistleblowing to make sure that people don't become imposters in this very delicate profession of medical practice. So thank you very much, Muno, for raising this very important issue. And I want to ask Dr. Clarence this question. Have you ever been part of any humanitarian mission out of Germany to any part of the world?
Unfortunately not.
Okay.
But there were endeavors on my part, as you've seen with the pictures I took in Shisong. Almost every time I visited, I went over to Shisong to at least to get to know those who were on the ground. Charles Mbondo, who is the resident surgeon on the ground. I'm constant contact with him. And but I had my difficulties because, as I said, we were trying. My aim wasn't just to perform surgery. I was in contact then with Professor Bufong, the university in Bamenda, to also see if how all of these could be integrated together. But doing things from abroad, not being present, is not always as easy. And our aim to finally be one of the missions from our center in Chisong was never possible, unfortunately. But I hope sometime in the near future we're going to be able to make up for that.
It is our hope that through the town hall we can coordinate effort and expertise to be able to organize such a mission in Cameroon to help the population. Brian, what do you think about that?
Yeah, I think so. I think we definitely need to more cohesive efforts. That probably be the best approach.
Great. And that's a big responsibility to our chair, Dr. Muno. I know you do a lot to put this together, and your leadership and expertise is what has kept us here for all the sessions. So I want to ask in the town hall if there are other questions that you have for our presenter for today.
I think Etienne had his hand up. Do you want to?
Yes. Etienne, you can take it from us.
Well, yeah. Okay, thank you very much, Dr. Clarence. I'm Etienne Nge, based in Bamenda at the moment. I'm a physiotherapist, though trained as a cardiac rehabilitation specialist. I think I've lived, I can say, most of the experience of what we've discussed here today. Train outside, come back home, and difficult to find yourself into a platform where you can actually use your skills, with ease and save a greater mass. Dr. Cabra was here, I think, but he left. I've not seen him. He's a cardiologist. He was in Shishong, now he's in Douala. And if he was here, he could testify how difficult it was for me to actually just convince the sisters of the importance of a cardiac rehabilitation program to be set for the center, because I was of the opinion that you cannot have a center like that without actually a cardiac rehabilitation unit where we look at more or less rehabilitating and helping people after intervention to actually get back their physical capacity or strength, and then even look at other aspects that can improve quality of life in general. But it was so difficult that they asked me to make a document showing terms of the program. I did. And then when they called, they said I should call this sister. At some point, they said they have to send it to room or so. And finally, I called. I used the Dr. Cabra, Tancho, but yet nothing happened at the end of the day. So it is a very difficult situation, really. I think we have a big problem, like I said in the chat, because we hardly will analyze things, from the top. Those at the top, or problem of leadership generally, where we analyze things and look at it from a very leadership perspective, like what do I do for the people in better to gain from this program or intervention. Most often it is purely business oriented, and that's one thing.
I don't think, am I the only one who is not getting?
Yeah, we lost him, maybe because of network.
All right, but I'll just continue what he's saying, because here in German, there's a saying, du kannst das Rad nicht neu erfinden. You can't reinvent the wheel. And
I wish to be sustainable.
He's back.
You can continue. I think we lost him.
All right, and talking about cardiac rehabilitation here in Germany, for example, is an integral part of cardiac surgery. It's equally as important as the surgery which is being performed. So if you can't do the cardiac surgery, and the patients are almost always mandated to go after that for cardiac rehabilitation. There you have enough information, you're being trained and prepared even for life after cardiac surgery. So you can't have that program running without appropriate rehabilitation after that. So I'm just like supporting what he has to say on that topic. Yeah.
Great. Thank you very much. And we'll be wrapping up with the session for today, and I'll go around with our moderators to give their words, last comments before we say goodbye. So we'll start with Christel. Christel?
Thank you, Elvis. Thank you, everyone. Thank you, Clarence, for this very nice presentation. And thank you for everyone for attending. We hope that the lesson or the words, the take-home message we got today will be fruitful for each of us wherever we are in order to build something sustainable, both in cardiology and elsewhere, and then make things to happen in one way or other. Thank you.
Thank you. Brian?
Yes, really, unfortunately, we just missed Etienne. I think he was making some really important points on cardiac rehabilitation in Cameroon, and being based in Chisom was even better. Really, thank you for everyone for the participation. I think the take-home message from here is really inspiring. Just a lot of things to think about, a lot of things to move over. And really want to thank you, Dr. Clarence, for sharing, and everyone. Thanks a lot for your participation.
Great. And Dr. Clarence, some last words for your audience before we hand over to the chair.
Well, I want to thank you all for the opportunity to be able to present at the town hall. This is a topic which is very dear to me, and I hope, as I told Dr. Changtak at the last time, that we aren't going to end just by talking. We're going to have to get practical sometime, and I hope it's sooner than later. Thanks.
Thank you very much. And now we hand over to our chair, Dr. Muno.
Yeah, I just want to thank Clarence and say that it's times like this that we get to really understand the importance of getting different levels of care back at home, and also educating our people back at home in order for them to advocate for their health care and to advocate for something better, to also advocate for the healthcare system. I think your presentation actually touched into every facet of healthcare system building in Africa, right from trying as much as possible to get an infrastructure in place where the healthcare workers are going to be kept in sustainably in order for them to be able to do basic and fundamental activities that are necessary in order to feed into the tertiary healthcare services that are offered by certain specialized, different specialized entities that exist in our system, both in cardiothoracic surgery, neurosurgery, advanced oncology surgery, advanced oncological care. I can see Dr. Mbako, before leaving, talked about a model in Douala providing oncology services right now. All of these things are really lacking in the basics, but we are even unable to diagnose these problems because even if we diagnose them, we're unable to take care of them. So no one even puts this extra effort. It's like a chicken and egg problem where you don't know where the problem is coming from. Is it because the doctors don't want to diagnose it in the first place because no one is going to take care of it? Or is it because there is no one to take care of it? That's why no one is being diagnosed. So I think you have been an eye-opener to us all. And the town hall is going to work with you, and you will lead us also guide us in order to see how we can go forward in educating our people about cardiothoracic surgery. and also trying to collaborate with those who are back home, rekindle maybe a mission in Shishong when the health crisis and all the crisis gets better back home, and see where we can go from here. So Clarence, it's a pleasure. Clarence is my classmate and my friend, and I'm proud, very proud to have him. Each time we're talking, I was laughing. He said, why am I laughing? But I'm laughing just because I'm so proud of how far we have come. And it's a pleasure having you in the town hall. The town hall belongs to the people of Cameroon, belongs to the health professionals, both the scientists, the lab technicians, the nurses, the pharmacists. Everyone should feel belonging. This doesn't belong to Elvis, nor to Brian, nor to Christelle, nor to anybody. It belongs to us. So we should take the town hall to whatever level we can go to. And if we have projects that we think the town hall can help you get those projects in the air, but the town hall is totally non-financially bound, but we actually help a lot of projects in order to move them forward. So if there are speakers here, people who want to come in and educate us, educate the public about topics coming up. I saw my friend Basil logged in today, and I really want him to come in here. He was honored to be one of the most highly appreciated physicians in the US, and I would really want him to give us a talk on something coming forward. So Elvis, I hand over to you, and I say the town hall belongs to all of us, please. And thank you very much for always being there.
Thank you so much. You are really a very servant leader, one of its kind. Thank you for all your leadership and for all the work you do backstage. Ladies and gentlemen, we really want to thank you for this session, and we want to thank our guest speaker, Dr. Clarence, who told us that cardiac surgeons are people who repair what is spoiled in the heart, and that sometimes they don't only repair, they also transplant and put another heart in place. And he looked at what it takes to put together a system that can function well for cardiac surgeons. And he said infrastructure is key, as well as having trained and qualified personnel and equipment. But he gave us some statistics and said 39 million people live with romantic heart disease in the world. And this is disease of poor people, and that those at risk were people who are young people, mostly within the age of 40. And we know that Cameroon has a broad-based population, looking at a population pyramid, where majority of the people in Cameroon are young people. And so then it becomes a very serious issue for romantic heart disease in Cameroon. We heard also that 17.5 million people die of cardiovascular disease in the world, and that majority live in low and middle income countries. Of course, Cameroon belongs to that category. And we're looking at the different models that could work when it comes to having cardiac surgery in Cameroon and also in sub-Saharan Africa as a whole. And we look at medical tourism, humanitarian missions, as well as, you know, just humanitarian surgeries. But he also said it takes about 15 years to put in place a system that can run on its own. And we look at the cost of cardiac surgery, for example, in Shishong, where we saw that about 4,500 euro was an average cost for a cardiac surgery to be performed. And considering that Cameroon is a low and middle, it's a very poor country, if I should put it that way, where some part of the country people live on less than $1 per day. Then we also saw the need for an insurance system that can actually cover even the underprivileged to have access to care. And so he said, in order for us to have a proper system, you need finance as well as a well-functioning health system, an insurance policy that covers everyone. And of course, he emphasized on political will. We also heard from Dr. Taka that we cannot set up a center that would not have an inflow of patients that is adequate to run that center. So then there is need for diagnosis. We need to be able to perform diagnosis and be able to diagnose people that have this problem in order to refer them to these centers if the centers exist. And we had questions from the audience surrounding issues of behavior from professionals who go back home. We've talked about issues of sustainability and keeping those who have studied out and gone back home, how to sustain them and incentivize them to stay back home, the different strategies that can be used. We also heard about the strategy in Germany, where there is a system in place that can pay salaries of those who want to go back home for up to a certain number of years. And that is a very great way of sending back our expat home. And we also talk about possibilities of the town hall looking forward to organize in collaboration with the different expertise in the house, how to carry out a mission, a humanitarian mission in Cameroon that can help our people in this domain. These were just a few highlights among many things that were not captured, but I want to say thank you so much for being part of the town hall for this week. We look forward to seeing you again in a fortnight. It's always a pleasure having you. Accept warm greetings from Alison, who just tuned in for 15 minutes and left because of other commitments. Accept greetings from Louisa, one of our moderators. It's always a pleasure having you once again. Have a wonderful weekend, but don't forget, there is the parking lot where other discussions take place. Stay blessed. And it's voted. Oh, who is
again?